Hope everyone's enjoying the conference thus far. I think it's been a pretty good day. Just those in the back, come on in. There's lots of seats. Just filter on in. Have a seat. The doors are closing. We're locked in. So I'd just like to welcome you to this session on using patient outcome data to drive improvement. My name is Craig Mitten. I'm in the School of Population and Public Health at UBC and a board member of the council, and it's a real pleasure to be here with you this afternoon. This is part of our rapid fire sessions, so each presenter or presenting team has 20 minutes total. And so I will, without further ado, turn it over to Nechelle Wall from BC Emergency Health Services to do our first presentation.
Thank you. So my name is Nechelle Wall, and I am a paramedic practice leader with BC Emergency Health Services. As many of you may have noticed, that is not what you were expecting to hear today. But we had a bit of mix-up. So when we were doing our low acuity presentation, we actually had our cardiac arrest outcomes one in that portal. So we just rolled with it. So now we're going to talk about this. And it does really loop back to using patient outcomes, though, to drive change. So we'll talk about that. And I'll just click play. Green it is. Okay. So I have nothing to disclose as far as any relationships with commercial interest. So historically, when we look at a pre-hospital system and what that process looks like for a patient when they call 911, they call 911, we have an emergency medical call taker that answers it. It then goes through MPDS, so medical priority dispatch system, where it receives a priority and an MPDS code, and it goes to the dispatcher, where it eventually has resources allocated to it. From there, we get the paramedic response and assessment and conveyance, and that typically ends up in the emergency department. But we also have a system in BC that covers over 900,000 square kilometers, 750,000, calls per year. And of those, 60% of those calls are low acuity in nature. So they're non-emergent. They're low acuity. So we ask ourselves then, what can we do to improve the system? Is going to the ED necessarily the best thing for these patients? Or is there something we can do better at the pre-hospital level? So we built out these processes. So what we initially did is we looked at how can we fix the system. So if we create a secondary triage process using a Manchester triage, and then from there, and these are for low acuity patients. So we'll talk about that a little more, how they get funneled into that. But if you are deemed to be a low acuity patient, you will now go through a secondary triage process. It's a paramedic, either a primary care paramedic or an advanced care paramedic that will answer this phone call. So they'll call you back and they're going to put you through another triage process. From there are multiple different things that can happen, including recognizing the call is quite serious and MPDS missed it, and we can upgrade it quicker than it would have if it stayed in the normal queue. But we can also take that and we can loop them back in now to UPCCs and refer them back to either UPCCs, eventually virtual health. We're able to use Good SAM through partnership with the Office of Virtual Health. And as well as we can send them different kinds of responses. So not always just an ambulance now. We might send them a low acuity response unit. And like I said, we might end up at a different destination now. So we're really like, let's develop a process that meets the needs of the patient and, increases efficacy in the system. Oh, I'm going backwards. Sorry. Okay, so secondary triage, it's in trial phase right now. So what we initially did, we created this secondary triage process, and how that looks is we've taken MPDS codes. So we went back and we did these are the MTS cards, so these are the actual secondary triage cards that can be used. And what we did is, when we created this, we looked at the MPDS, so the normal dispatch system. And we went in and we looked at all of the patient care records through a retrospective analysis, and we determined in this which MPDS codes represent patients within our population here in BC that are safe for secondary triage. So we did that by performing a risk stratification using the NEWS2 scores and shock index, as well as multiple other factors, including if they were determined to be ambulatory. And then these MPDS codes that you see on the left-hand side here, like 01 alpha 01, they would be included if they met an inclusion of 80% or more. So this is just a small picture. In total, we identified 14 in the initial audit, NPDS codes that are appropriate for secondary triage that represent those patients for low acuity care. So of those 14 that we identified to be appropriate, just to put that in perspective, they represent almost 6,000 calls a month. That's 6,000 patients that we can be redirecting to more appropriate care, be it either virtual health, connecting in with like UPCC, conveyance, but a different approach that doesn't just end up at the emergency department. Going backwards again. Next, we built out, like we decided we need to build out the system further to maximize it. So we brought on employees that we call low acuity patient navigators. These employees, they really are the glue of the low acuity system. So they're responsible for identifying these calls in the queue, apart from the secondary triage clinician, and making sure that we're sending the appropriate resources to them as well. So to our low acuity response units, making sure that we're targeting them to what might be A-star appropriate patients, and our A-star is our assess, see, treat, and refer, and that's usually a non-conveyance pathway that results in the patient being left at home and actually not being conveyed to any other healthcare facility. We also brought on the low acuity response units. So these low acuity response units, they are staffed by one paramedic, and they are targeted specifically to these low acuity calls. So when these come in and they're identified within the system, now we can target them using these low acuity response units, and we've actually been able to increase the time, or decrease the time that we're able to respond. So, and these paramedics, they actually undergo further training in the specific pathways we do and like these low acuity approaches to care, so they really go in with that mindset as well. We then take the data that we get every month, and this is what it actually looks like when we report it back now into our system. So we take this data and we report it back to the system. This was a snapshot earlier on, but every patient care delivery manager gets this. So they look at how many A-stars we're enrolling, how many we're missing, secondary triage performance, how many patients are going to UPCC, and this then gets fed back to our partners in the healthcare system as well to see how we can increase these enrollments. And now that we've implemented it and we've kind of began that trial phase, we're really now in the evaluation phase. So it's been ongoing since early January. And since then, we've now said, okay, we brought this in because we recognized a need in the system to change our approach to care. Like many other, organizations, it was driven a lot off COVID and some of the other challenges we faced following the heat dome. But now that we've implemented it, we need to go back and actually make sure that we can really evaluate the system, and the system is able to feed back in, and it really has that resiliency. So we're using the quadruple aim evaluation. So in the last couple months, we've actually engaged patients through Patient Voices Network in interviews to understand their overall to understand really how they feel about the system. And it's been actually very overwhelming, the response and these new low acuity approaches to care. We've also done experience surveys for any patient who's been enrolled in any sector of this, as well as we've engaged clinicians through clinicians surveys, and we've now began to validate not only the queue, but to look at clinical outcomes for these patients who have been enrolled over the last few months. As well, we are doing a cost analysis to see what the impacts of this are, at least on our organization at this time. So, questions?
It'll be an easy one.
Okay.
Just wait for the mic.
Thank you. Great presentation. Just want to know what areas are these low acuity units being utilized, and what is the plan to roll them out to the other health authorities?
Yeah, no, that's a great question. So right now we have low acuity units in most of the lower mainland. We also have them in Kamloops, as well as there's going to be some rolled out in Northern Health, primarily in Prince George. So that's specifically the low acuity units right now. When we look at UPCCs, we initially started with UPCCs, just partnering with us in Fraser and Vancouver specifically within Lower Mainland, and we've actually been able to really expand that out. And when we talk about alternative destinations now, we've been able to grow it in partnership with the health authorities to not only just UPCCs, but to sobering sites and mental health sites. So it's been really great, kind of how the trajectory right now.
Hi, Michelle. That's awesome. Thank you very much. Just a quick follow-up question in terms of the outcomes. Did you have a chance to follow up any of those patients being admitted to hospital after?
So with some of the UPCCs right now, we are able to get that, but as far as linked data, I'm not going to lie, it's a challenge for us in the pre-hospital world to get linked outcome data. It's something I think we're all striving for, and I'm definitely very passionate about it, but it is a challenge. So right now, when we look at outcomes, when we're looking at this system specifically, if we're saying these patients are safe and they don't need an emergency response, the way that we're approaching measuring them right now is, right now the patients, they always will always have the option to say, you know what, no, I want an ambulance, because it should be patient-centered and shared decision-making. So when our system says these patients are safe and they don't require an ambulance based off this process we've built out, but the patient requests an ambulance and they have one respond, we go back and we look at that data specifically now too and say, okay, have we missed anything? And we measure it against very much the same. So the NEWS 2, the shock index, any critical interventions required. And that right now is kind of the closest we're coming to saying, are we missing something? But that's the limitations right now for us.
Hi, I just had a quick question. It's a great presentation. Just wondering about your connection with BC Nurse Line 811.
Yeah.
I'd love to hear about, like, from a patient perspective, we're often telling them to call 811 and then they get information, that ongoing conversation. Do you go kind of back and forth? What's the consistency, measurement, conversation?
Yeah, so there is actually engagement with 811 and HealthLink BC, as well as, like I said, Office of Virtual Health. So that is something like a partnership that's relatively new and ongoing, and that we're looking to kind of really align our visions and goals. And I think that's really important, like, as we look at, like, not only our role, but like how our role impacts the system, right? If we can, and not only patients, but the system level performance outside of just us. So the relationships are there, and they're definitely been beneficial. So,
and the reason why I brought that up is a lot of physicians don't like 811 because we often end every algorithm with go to emergency. A lot of people say that. So it'd be great to kind of look at what are those, where are we missing, what are the gaps, how can we avoid people in emergency waiting when they don't need to be there. So.
Thanks, Nechelle. Excellent presentation. And not even the one you planned.
it's been a day for me, guys.
But you didn't have a cardiac arrest, so you weren't in the, yeah. I'm just curious on the aggregate data, like the chief complaint, the reason for the call. Are there any themes that you're seeing so far with the initiative?
There's definitely themes. And when we look at like the process as a whole right now, secondary triage, one of our bigger ones that we're seeing is back pain. So non-traumatic back pain is actually quite a large one. And we're seeing quite a bit of abdo pain. And that's usually like a nausea vomiting complaint and not severe. So those are the two big ones that we're seeing now. And the system is quite new, so I'm definitely curious to see how that's going to develop out, especially as we begin to add in, like, because that's another thing. That's very biased by the MPDS codes right now that have been added in as well, right? So as we build that out and we're able to add in more MPDS codes and stuff, I think we'll definitely see more patterns emerge.
I have a question about a different theme. I'm wondering if you have stats on how many of these patients lack a longitudinal primary care provider. Maybe that's why they're making this call. Do you have any statistics like that?
That is something that we have included in our last round of the patient experience survey in our demographic data, but I don't have those numbers now. But I think that is definitely like, when even in the patient voices and stuff, that's definitely something like we hear across the board. It's that access to care.
Hi, my name's Robin. My question's kind of along the same line as the gentleman next to me, but I think it's fantastic to keep people away from the emergency department that don't need to be there. But at the same time, if we're not preventing people from getting sick by having primary care and we're sending people in a resource-limited setting to episodic family physician reviews, are we kind of kneecapping ourselves by not having longitudinal care, but having people working in those cases in UPCCs?
I mean, I think that's a very big question. I think it's very hard for me to answer because I think that comes down to, again, like it's that patient experience. It's what matters to the patient, and when there's access issues, and ideally, yes, in a perfect world, kind of like that debate, we would have this. beautiful access to care, but it's just not the world we live in right now. And I think for some patients, this makes a lot of difference. These processes that keep them out of the hospital, that loop them in and back with, like, even a lot of them, like, it's simple wanting to have a prescription refill, right? You know, a lot of them speak to not wanting to be in the hospital for 6 hours waiting for that, and, you know, waiting for us for 4 hours to show up, right? If we can, and I think another thing, I think this has a real opportunity through, like, collaboration with other health partners and the health authorities to become a point of access back into care too, right? So.
Thank you for your presentation. I'm curious to know, going back to that patient survey, what was the general sense from patients and families with this new model of care that's being provided to them?
Yeah, so that's actually like a very new evaluation, so I'm going to be very happy when we're able to kind of release the results to you. But it was overwhelmingly positive. It was overwhelmingly positive. And there was parts of it that actually shocked me, even when we talked about alternative, like, conveyance. Patients were okay with it. And a lot of them spoke to, like, yeah, no, I would be totally okay with having one paramedic show up in a van, because it takes away that barrier that I had in, like, going to the hospital myself, right? Like, if I can sit up and I can walk, then I'm totally happy. And, like, I think for us, you know, especially me being a paramedic for so many years on the streets, it was a bit shocking because I have this bias. It's like, oh, I guess you get used to, like, you show up in the ambulance and we go in the bed and stuff. But patients were very, very supportive of this. And it was really interesting. One thing that almost in the patient voices groups that almost was ubiquitous across all was not only at a patient level, but they were excited at a system level and a taxpayer level for how we could increase system performance. And I thought that was very interesting because you want to hear their perspective as a patient, but they're also like, hey, my perspective as a citizen. So.
Thank you so much for your presentation and for taking the time to explain so well this new initiative. You mentioned during the low acuity response unit that there's one paramedic who works on that unit. Is there a feeling of safety having with only one respondent, and has there been any safety issues with bringing only one respondent to a call?
Yeah, so that's actually a great question. I think it's actually something that we do train for. So if you're going to be working in a lone responder capacity, there are actually mandated WCP courses and training that you have to do, as well as certain processes in place for these paramedics to be able to check in and have that open line of communication with the dispatchers. So, and at the end of the day too, we always do have the right to refuse any work that we believe to be unsafe, but does it add a degree of inherent risk? Almost certainly. I don't know if the risk outweighs the benefit though when it comes to this. So I think, like, for the most part, we have great dispatchers and great call takers, and they're usually able to identify pretty early on if there's a threat on scene. But okay. Thanks, guys.
Thank you, Nechelle. Great stuff. Great presentation, and look forward to the evaluation results as they come in too. So fantastic. Our next presentation is from Falla and Soojin Kim. So welcome, and the floor is yours.
Good afternoon, everyone. Thank you so much for giving us this opportunity to share our work with you today. So we wanted to talk to you about our initiative about patient-centered care for patients with complex medical needs, specifically from the role of patient-reported outcome measures. I'm Soojin Kim. I'm a surgeon at BC Children's Hospital and an assistant professor at UBC.
And I'm Falla. I'm a research assistant at BC Children's Hospital Research Institute, and we have nothing to disclose.
So to briefly introduce ourselves, we are a spinal cord clinic at BC Children's Hospital. We're composed of physicians and surgeons, as well as nurses and allied healthcare providers, such as a social worker, PT, OT. We also have research and administrative teams taking care of these children. And where do we cover? We do cover a large geographical area, both BC and the Yukon. So that's about 1.4 million kilometer square area for catchment area. And what kind of children do we care for? So we have children with a variety of spinal cord conditions. This is an example of a baby who can be born with an open neural defect, or it can be infectious process in the nervous system. Lastly, it can be any unexpected spinal cord injury. We had a very active volleyball player who had a fall injury, or a very active hockey player who had just random diving accident during the summer, which results in a serious spinal cord injury. So how do these conditions affect these children? Many ways and many systems involved. So because it's a spinal cord injury, obviously it affects their nervous system and their nervous system status, which subsequently can also affect their bladder and bowel. It affects how the bladder and bowel empties and stores their content. Then subsequently it can even evolve into something like chronic kidney disease, end-stage renal disease, where they are dependent on dialysis or renal transplantation. It can also affect their bone or orthopedic conditions that require multiple surgeries that can be dependent on mobility aids, walkers, or wheelchair. Last but not least, because it affects so many of their systems, it can affect their mental health, their psychosocial well-being. As alluded, these conditions can or may affect and result in neurologic, orthopedic, and/or urologic morbidities. They may be chronic in nature and requiring lifelong care. And they may negatively impact health-related quality of life and psychosocial well-being. Fortunately, we do have a very good multidisciplinary team. But our aim is to also provide patient-centered care. And how do we do this? Over 11 months, we had over 40 stakeholder meetings trying to find out what other aspects in their lives are we missing. And we decided to turn to patient-reported outcome measures. And these are the 4 aspects that we decided to look into, including transition readiness, health literacy, quality of life, and mental health. Because no blood work, no CT, X-ray can tell us about any of these.
So here is a visualization of our project timeline. So our planning stage started in early 2020, and we also designed the project with our Research Institute's REDCap team. REDCap is a secure online web application where we store all of our study data. And the project is officially in implementation in November of 2020. And I just wanted to highlight that the whole project came to be during the middle of the pandemic and hospital curtailment. So we really wanted to make sure that the project is accessible to our patients both virtually and in person. And as of currently, the project is still going on, and we continue to do some maintenance work. So here we're going to present some interim results of our project. So far we have collected data on 87 patients, and as you can see that the mean age is relatively young, age 10, the mean age of 10. And you can see here there is a variety of different spinal cord conditions that we capture, as well as some different comorbidities. And also we wanted to highlight the total number of surgeries per patient is about 2 surgeries, whereas the highest number of surgery that one patient can undergo is 21, despite their relatively young age. And next, we also wanted to talk about that about 40% of our families travel more than 80 kilometers to see us in person at BC Children's Hospital. And this has been a conversation within our ongoing discussion within our care team to address how we can provide more accessible care to these families who are traveling so far to see us. And additionally, we also have about 30% of our patients that require some sort of social assistance. So the first survey we're going to take a look is transition readiness. So on the x-axis, you can see here the mean score is out of 5, and here are some of the subdomains that the survey look at. So as you can see here, our patients are doing pretty well in terms of their skills to communicate with our providers, which also suggests that our care teams is able to make good connections. However, on the other side, these patients are still lacking some skills in terms of tracking their own health issues, keeping their own appointments, and managing their medications. Most of the time, family members would take care of that. So these are areas that our care team, while the patients are still with us, our care teams can address with them so that when they are ready to transition into adult care, they are able to grasp these essential skills. And next, we look at health literacy. So health literacy is essentially how much patient understand the words that physician use to communicate with them. So you can see here for our teen patients, the average score is equivalent to grade 8 to 9 literacy, and their parents who have completed this measure is about high school literacy. So health literacy is important because it not only tells our providers how to communicate with our patients according to their vocabulary level, but it's also a risk factor for school failure and dropout, which is then associated with health risk behaviors. So we specifically look at the data from our patients, so these teens, and we plotted them comparing to their current school grade that they're enrolled in. So on the here on the x-axis, these are just individual patients. And here the blue dotted line represents the current school grade that they're enrolled in, and the orange line represents their health literacy grade that we assess them on. So as you can see here, these patients highlighted here, they score a lower health literacy rate than the current school grade they're enrolled in, which means that they could be at risk for some school difficulties. So these are patients that our social workers or occupational therapists can follow up on, and perhaps even working with their school to address some of the needs. And next we look at quality of life. So there's specifically the 3 subdomains. So the sense of independence and relationship, their bladder and bowel controls, and also their esteem and sexuality, which only pertains to our older patients. And the graph is divided into different age groups. So we have child, teen, and adult, and the mean score is out of 100. So first of all, we can see here, while the patients get older, their sense of independence and relationship actually decreases, whereas their bladder and bowel control remains relatively stable. And lastly, just wanted to highlight that our older patients express a lowered sense of esteem and sexuality. And lastly, we also look at their psychological well-being specifically, and on 6 different subdomains. So we have separation anxiety, generalized anxiety, panic disorder, social phobia, obsessive compulsive disorder, and major depression. So we did, so both kids and parents complete this survey. And we just did a count of the number of subclinical and clinical scores that came up on the survey. So we just wanted to highlight that overall about 11% of our children experience some sort of mental health difficulties in terms at either subclinical or clinical level. And about 30% of their parents perceive that their child experienced some sort of mental health difficulties likewise. And these are patients, when patients express any of these, the results are flagged and can be followed up by our social workers and registered nurse during clinic visits. And lastly, like I said, so the data we presented to you today is only interim results, and our long-term goal for this project is hoping that it can continue on for years and years, and we're going to be able to follow our patients throughout their time with us at the spinal cord clinic until they transition into adult care. And in preparation for that, we wanted to be able to produce a report like this that you see on the screen, where it has a summary of all of their patient-reported outcomes as well as their clinical information, and the patient can take this report with them into their adult care, and hopefully that would be useful.
All right, and this is number 1 lesson learned, and it's funny. It's from a book that I've been just reading, and just several days ago I came across this quote, and I thought it was perfect. You don't get to decide what this research is about, your participants do. You'll follow them where they go, not the other way around. This is based on their lived experiences, not the researcher's academic pet interests. Trust and follow what emerges from the data. So this really taught me to change my perspective and approach to care. Because the way I trained in medicine, it just asked you to come up with a question, specific question, focused question. But really, this is completely the other way around. You let the data show you, let the patients and families show you where they need help with, where they need the resources. So I still struggle, but it is the #1 lesson we learned from this project so far. And these are the future directions and current struggles. As Falla already mentioned, we want to use this initiative to identify areas for support and provide individualized plan for these patients. And we want this to be sustained for years to come. It's not just 1-year project, 2-year project. These patients live with these conditions for their lives. So we want this to help us to identify that. And like I mentioned, we want to shift our mindset, mine included, and all of our team members in our spinal cord clinic. We still keep asking these questions, but trying to shift our mind back to, okay, let them show us where they need help with. Thank you, and happy to take any comments or questions.
Can you talk a little bit about how you landed on the right PROM tools to use that would be the best fit for this patient population and their parents?
Yeah, so these 4 areas that are only 4, right? There are so many other areas that we want to look into. Patients would love to get assessed, but we also have to be very practical and realistic, especially as very early initiatives that we are taking on. So based on literature reviews and what they've been expressing and what the core sort of discussion's been happening, that's what we based it on. And we also chose specific prompts that are succinct, because we don't want them to have a survey fatigue either. So we try to be mindful of that. So balancing, it doesn't have to be a perfect survey that answers every aspect of quality of life, but something that we can still have like a snapshot of. So we have to definitely balance that and come to decide those 4 instruments. Not meant to be comprehensive, but enough for us to start with. Yeah.
Thank you.
I had a very similar question, but maybe if you could talk a bit more about the maintenance, and do you have a plan to update or adapt the survey if you hear different things from your patient population or new tools come out to make sure that you're staying as relevant as possible?
Yeah, that's a very good question. So this is another thing about shifting mindset. So this is not a set protocol that we cannot change. It's already finalized. It is an ongoing process. So even just we are just into year 2, and we already have other providers wanting to have a more dedicated assessment about their bowel status. So we are testing out a bowel instrument, PROM, to kind of look into that aspect. And there is another PROM that we initially had to reflect their physical abilities and mobilities, but we don't like the initial one that we chose, and so our physiotherapists in our team want to sort of look into that in more detail. So definitely modifiable on an ongoing basis. Yeah.
Hello there. Thank you so much again for presenting. With regards to respondents to the survey, did you provide the same survey to parents and children?
Yeah, so it's a different set, and we have different criteria for who gets what survey. So which we didn't mention here because of time, but so we assess them based on patient's age and cognitive capability, which is assessed by our registrars. So usually if patients are aged above age 8, then they will get their own set of survey, and if patients are above we have some patients at age of 18 or 19, then they would completely answer their own survey. But for younger patients or patients who are kind of having some cognitive capability, were identified by our nurse as in some cognitive challenges, then the parents would answer the surveys for them. So it's a very customized list of survey they get.
Missed it, but what percentage was answered by the children themselves and which percentage was answered by the parents?
Again, so that would also depend on their age and capability. So I would say for a child, for example, age 8-year-old and who's cognitively capable, they would answer most of these surveys themselves, but also parents get to answer the parent side as well.
Thank you for the presentation. My question is around, I noticed that majority of the patients in your cohort had spina bifida. So I'm assuming they were younger patients. And I'm assuming that majority of those patients, their parents answered the survey. What are your goals in regards to this initiative for long-term outcomes for these patients? And how are you planning on following up with their long-term outcomes and how they take care of potentially deteriorating bowel function or renal function? Could you speak to that?
I'll just clarify that yes, a lot of our patients are spina bifida, but because this is a long-term condition, so we see patients with spina bifida, 11-year-olds, 13-year-olds who we also see them in our clinic as well. So they definitely gets to answer their own survey. So some of the responses are coming from these kids themselves, and I'll let Dr. Kim answer the follow-up.
Yeah, sure. Yes, so in terms of how we want to use this as long-term care, so we briefly mentioned we do want to use this as our annual reviews. When we do have biannual and one large annual meeting as a team to go over how we are doing, so we can have individualized report as well as sort of overall our clinic report to see where our patients are. And briefly we showed sort of year 2 data, and we hope to see more years to build up from that. But seeing a trend for patient A, okay, why is their quality of life scores decreasing? And health literacy, not only school dropout, but how are they going to navigate through healthcare system? So that's a sort of like a proxy measure. So if that's decreasing and or it's sustaining, but it's constantly below their grade level. So those things will really help us to guide, okay, they need more resources in this aspect, or more extra attention in quality of life assessment or transition readiness. These patients are expected to go into the adult world where multidisciplinary care is not going to be available. They have to initiate their appointments with orthopedic surgeon, urology, and pediatrician or psychiatrist, and how are they going to do that? So transition readiness, from age 12, we start collecting these scores and can hopefully direct us, okay, they need more help with medication management. So that's our goal. It will help us to guide where to put our resources and attention to, so that we can help in those specific areas.
Thank you so much.
Thank you.
It's a really great presentation. That's fantastic to see PROMs in action. Our last presentation is from Antony Porcino and Michael McKenzie from BC Cancer. Over to you two.
Well, mostly from Antony Porcino, but I'll introduce myself. I'm Michael McKenzie. I'm a radiation oncologist at BC Cancer Vancouver. I'm the lead for the EPIC project you're going to hear about. So I'd like to do two things. One, I'd like to express gratitude to Canadian Partnership Against Cancer for supporting this work that you're going to hear about. And I'd like to thank Antony for all his hard work, because without that hard work, we wouldn't have achieved the success we have. So Antony is the project manager for EPIC. Take it away, Antony.
Thanks, Michael. So again, we have nothing to disclose, and we also, as standard for our program, we want to acknowledge the lands which we work are with from the Coast Salish peoples. Thank you. So BC Cancer's early symptom indicators for cancer care, or the EPIC project, as he said, is sponsored by CPAC. And we are a pilot project to integrate repeat symptom screening for physical symptoms and psychosocial issues into standard care at the Cancer Agency. And in research, we know that repeat symptom screening has a number of very important long-term outcomes. It shows improved quality of life for cancer patients, better end-of-life treatment and decisions and place of death, which are quality markers for long-term care like that, and improved health system efficiencies and cost savings as well. Depending on the cancer population, you may also actually see extended life. When you're looking at patient-reported outcomes, some people ask, well, how could this be happening? This is one of the things that's going on. The yellow lines are patients reporting on their symptom severity, and the blue lines are healthcare providers reporting on what they perceive the patient's symptom severity to be. And you can see that there's definitely gaps in perception. So this is one of the drivers behind the use of patient-reported outcomes. They've also shown that healthcare providers themselves don't even agree on a single patient what the symptom severity is. So what we're looking at here on the right there is actually one of our patient screens. They've done several. And one of the things that you're seeing there is a standardized bank of results. And this allows healthcare providers to see an instant snapshot of what's not only happening in the moment at the time of the current screen, but when the screens start to build up, you start to see patterns, and you can prepare for anticipatory guidance in what's going on. That's the ESAS on the middle one, the blue lines, and you'll see that up ahead. Those are the symptoms: pain, tiredness, drowsiness, and so on. The other thing that this does is it doesn't require the patients to just sort of bring to mind what's going on, or maybe if you just ask a patient what's going on, they'll highlight one or two things. This allows you to get a consistent bank of data about them. So the EPIC project, Quality Improvement Project, is said to assess and address the permanent integration of this kind of screening into standard care. And again, this is early screening. You don't want to just start doing this with advanced cancer patients right near the end of their life. You want to start early. That's what shows the greatest impact. For us, though, as a pilot, we want to look at what are the barriers and the support for this kind of integration. So we focused on a number of patients with high symptom support needs, patients receiving palliative radiation, and those with incurable breast and gastrointestinal cancers. And we did this at 2 cancer centers, the Vancouver Centre, which is the largest and most complex of the centers in BC, and Prince George, which is a very small, tightly integrated group, but they also have to do a lot of rural and remote issues. So our intervention is multi-pronged. Obviously, the biggest thing is delivering the actual screening to the patients, and this requires a certain degree of model of care education. How do you integrate this? What are the jobs of all the people involved in doing this process, and how do you walk them through actually integrating what seems really simple? You're just doing a screen. It's actually really complex to work in. So a lot of education about how you respond and making sure you're using the skills and the knowledge of the staff that they're already using as part of their standard practice. We also have supportive education, and we focus specifically on serious illness conversations training, so how to engage patients when they're faced with difficult symptoms and decisions. And palliative skills, we use the Pan-Canadian LEAP course to help the healthcare providers respond in the moment to palliative care or symptom need management. Our actual surveying of the patients, getting their PROMs, occurs before the physician or nurse appointments, and they complete a short set of PROMs. I mentioned that ESAS earlier, the Edmonton Symptom Assessment System, which is a tongue twister, and that one happens at every single screen. The other ones, the Canadian Problem Checklist, malnutrition screening, EQ5D5L, which is a quality of life, which is part of our economic evaluation, and questions on advanced care planning. These are done less often because they are issues that change more slowly, and therefore we can help reduce patient burden about doing these kinds of surveys. The screening is on an iPad if they're doing the screening in clinic, or we can send them a link, thank you COVID for making that possible, to them a day before, and it really speeds things up. We then have dedicated nursing time to do a review of the screens, and the nurse actually collaborates with the patient to discuss on what's most important to focus on in the moment and to prioritize other needs and referrals and so on. Patients also receive a copy of their trended results on an ongoing basis. I'll just give you a moment to read these rather than me trying to read through them. We do have 21 different kinds of measures. And you can ask specifics at the end if you'd like to know more. So here's some of our data. It says there to date. This was to date by late April. So we had 860 patients enrolled, and those patients had done a total of 1,191 screens in just over 2 years. Again, that Edmonton system at ESAS, we found that 2 out of 3 patients were actually considered highly stressed in 1 or more symptoms. And in the Canadian Problem Checklist, about 1 out of every 3 patients was showing this, symptoms of high distress. One of the great things about this is that we can also get much more granular. So for example, you see 1 out of 3, up to 1 out of 3 on the malnutrition screening tool. We're able to see that that was mostly spread amongst the palliative radiation and those with gastrointestinal cancers. We also asked nurses to keep track of the time that they were taking to respond. And so you can see the average time, 12 minutes, 8.5 minutes, depending on whether they were in radiation or they were receiving systemic therapy. Really important to recognize that the range was actually 1 to 90 minutes. And so being able to look at this in advance, being able to see these screens early on actually allows the clinics to start to plan ahead, because they can see that some patients are actually highly stressed and have very complex symptoms. They can actually start to plan for the care around that. And that's really one of the visions as making this part of standard care, is to be able to integrate that flexibility into planning patient visits and patient time. The other interesting result that we found was advanced care planning engagement, which is really important for everyone, of course, but for cancer patients. And we found that in the same clinics, for the same population, so patients with these metastatic cancers, for example, if they were actually engaged in the EPIC process, there was a significant increase in engagement around advanced care planning. We also talked to patients. How do they perceive this? What are they finding about this kind of service? 2 things that I really want to highlight here. This top one, this allows us to bring up concerns I might not otherwise, and to know, you want to know about these things. They didn't know that we wanted to know about as much as we were actually asking them about in these surveys. The second one, it's very calming. I don't have to hurry up and get stressed that I'm taking time for unimportant things with my doctor. They're actually talking about symptoms as being unimportant. When they're with the oncologist, they want to talk about their treatment issues. So they were so thankful that they actually had this up to 15 minutes or more if needed with a nurse to go into symptom issues and care issues. So patients are actually talking that they appreciate having a multidisciplinary environment in which to receive care, and they are actually separating out the types of care internally depending on who they're with. So this gets really important if they're with their doctor and the doctor says, well, what's going on with you? They might not bring much up. And again, this goes back to why it's so important to have a standardized symptom bank for patients. Healthcare providers, I'm just going to really, the top one there is really speaking to interprofessional practice. So the healthcare providers were also really recognizing in the quotes we heard from them about how important it was that they were getting all these different aspects of care brought together and more efficiently delivered. And also the nurses really specifically said this is how nursing is supposed to practice, because they had that dedicated time with patients and people were enjoying the work more who were on the team. So it's really exciting. Lessons learned, we really have to be prepared for that follow-up time variability. Integration into standard work processes requires both new processes that we are introducing, but really taking advantage of what's already in the system, because it facilitates that integration much more easily. We do need champion roles. You need champions with change management to really support that ongoing facilitation of the integration. Sustainability planning. Healthcare is interdisciplinary, and if you're going to do some kind of process like this, to really bring together the full team to discuss the impacts and how it all best works together. And that also includes the patients. We have patient partners on every single one of our committees, and they are an important part of our team. And healthcare provider and patient feedback both indicate strong positive experience overall, and especially in systemic care. So this is like really positive feedback that helps us move forward. Our next steps, handing this project over. So I'm a project manager, I'm time limited, and we're now, so we have to think about where's this going. So we're really working on this component in our final year of how to get the staff to own it. And many of the staff do want to own it. So that's really positive. Integrate EPIC into the broader models of care processes. So again, we're a pilot project, but it has to be part of the bigger vision and built in early about how to make this standard care. And so that's where we're at now, is really building that in. Establish dedicated roles of interprofessional champions. So again, because care is interprofessional, we always have to keep that interprofessional lens in if it's really going to be brought in by a team and owned by a team and not just one profession. And the final thing is to support a vision for integration of a patient portal. And so, there's already some patient portals that are in use, but being able to actually collect PROs, report that back to patients, report that back to the healthcare providers, create emergency flags, all these kinds of things. Looking ahead, how can we build PROs into whatever we're doing because of the information that they can actually give us in support of patient care? Really important. With thanks, and this is a screwed up sentence I just saw, thanks to the past and current members of the many groups, the people that are involved in all of our working groups, and specifically to our data analysis collaborator. We do a lot of work with her and really helpful. Thank you, Acuity. So, thanks.
Thanks so much for a great talk. Just wondering how the PROMS results are integrated with your EMR. Does the frontline oncologist, right before the patient walks in the room, have to go somewhere separate to look at the results of those PROMS, or is it integrated with Cerner or whatever EMR you're on?
So I realize just as part of that answer, you probably saw it written. I didn't mention, if the patients are filling these out in clinic, it's on an iPad. And they come in half an hour beforehand in order to be able to do it. Or as I said, they can do it online. It's not directly integrated. The BC Cancer has a system called PAUSE, Prospective Outcomes and System, do you remember integration?
Patient Outcomes and Support Initiative.
Support Initiative. Yeah. So it is actually an independent system at this point, but all healthcare providers have immediate access to it, and they can pull up the results almost instantly. So, again, that's part of the importance of a patient portal.
No, that said, I mean, purposefully, the proposal I wrote for this was with the idea this was primarily nursing intervention, although it really is about the team. But the idea is, particularly for these high needs patients, it's the nurses and the team that are going to be taking a look at the pros before the patient's put in the room.
Thank you for the presentation. I'm curious to know, to operationalize this model of care, do you foresee the need to hire more nurses, specifically knowing that this might be a potential added work to their workload, or is there a way that it could be balanced with other workloads?
Maybe I'll field that. So these developments are arising at the same time that ministry has provided resources for additional staff for models of care work in BC Cancer under the banner of something called One Team, My Team. And so our understanding is over the next couple of years, the FTEs will be there, and what the advice we're providing provincial and regional center leadership is how to devote those extra FTEs that are already coming. So fortunately, we don't need to say, okay, we need 100 more FTEs, because they're kind of already coming. We're just harnessing them in the right way, we think. Did you want to add anything to that?
I also want to say that's one of the reasons why we were collecting the nursing time data to actually understand what the impact is for the patients most in need. And we've seen data from across Canada, so other provinces are doing similar projects. And so it's possible to, the impact in FTEs was actually less than what I initially imagined it could be. And again, we have to remember that nurses were doing some of this work. It was just not documented. And so this is also providing us that data to understand what the impact is on the system. So it's less FTE than we were expecting.
Hi there, and just a question in the back. This is a very interesting project. Thanks for this. And your intervention seems very comprehensive, and I think some of us in the room struggle with making sure that we can record and replicate the intervention, because if it has such positive effects, how can we disseminate the information and implement it in other areas and ensure we're doing the same thing? We have drug studies where we will give a blue pill and a placebo blue pill, and it's very simple, but these are much more complicated. So do you have any tips for us as a group on how we can capture our interventions so they're really replicatable and we can disseminate the same interventions in other places?
Well, with this work, we're very lucky because it is funded by the Canadian Partnership Against Cancer, and the way that partnership works is there's a cohort of other people doing the same work, and the idea is to spread the approach so that it is relatively standard across Canada. It's a little more difficult, I would imagine, trying to do this kind of work in other contexts. But you know, sustainment and spread is a challenge with this, even though we are working with CPAC. So a really, really good question. I don't have a fabulous answer for you.
I would add to that, though, that I think it's really important if you think about it in terms of knowledge translation or long-term use or application, even in research trials, to really think about what is the long-term goal, how is this sustainable? You know, I often, in clinical trials, you often end up just leaving and the whole thing falls apart. And so if you have that extra lens on and bring the people into the team that could maybe help consider issues about transition would be helpful.
Hello there. Thank you so much for your presentation. I found it clear and easy to follow, and I'm encouraged by the work that has been done here. You mentioned that there were 890 participants who ended up completing the responses, and you also mentioned that these were provided by iPad and by survey. I'm wondering what percentage of the study population actually completed these surveys in iPads? How many people actually clicked? How many people who were eligible engaged in these responses?
So in terms of eligible who participate, we had about 5% refusal for various reasons. Sometimes it's actually family refusal, saying that they're too ill, they don't have the capacity to do this. So we did have a certain percentage. In some cases, the healthcare providers also decided it was not in the best interest just because of the state of the patient. Most patients participate quite happily. The other limitation was that, again, because of patient burden, we do not actually give them the surveys at the first meeting with their oncologist, but the second meeting, and then repeating on after that. And so we have about 1/3 of our patients have an initial consult with the oncologist, and they may go through treatment or they may decide not to do treatment, and they end up not actually having a first screen. And this is also true for new patients. So we do have some data because the same kinds of prompts that we're collecting in our survey are the same as part of the patient intake. So we do have a little bit of leeway there. The majority of them, I'm just pausing here because it changed. And once we were able to start actually delivering these surveys online, the iPad was a bit of a limitation. We did ask patients. There was not a huge technology barrier, although we did find that with about 1/4 of the patients that nurses were spending time to actually help them fill out the surveys on the iPad. We don't know how much, we haven't got the feedback, how much of a barrier the online surveys are. I will say that if they haven't completed it online, and they're doing a virtual consult, the nurses will actually do the survey with them over the phone, or if they come into clinic, they will do it on the iPad at that point. So we have a fairly high completion rate and participation rate, at least in the ESAS. The more surveys or the more tools that we use, it does tend to drop off a little bit, but they've been pretty good at going through all of them. I've been quite impressed.
Thank you for that presentation for me as well. I'm curious about, you kind of alluded to this, but this is a great resource, just similar to the BC Children's study, where you can learn a lot from this data for your patients, but it also has potential for application to further research, particularly if you're linking the data to other sources like clinical data sets and if you're sustaining it as part of a standard of care. Do you have consent from patients now, or is there a plan to ask for patients to make that data available for secondary research purposes, or is that something your team has thought through?
Yeah, well, we did get, what do they call it, a notice of rejection from REB, so we could publish on this, for example, but I know that's not what you're asking. Not specifically, to answer your question. I think there's a lot more work we need to do nationally along this line, and we're talking about that at the level of something called the Canadian Cancer Trials Group, but I don't think we'll be using this data set for secondary analyses.
And I'll just add, generally, this is part of standard care, so it's a sort of a broader, it's certainly, if people are using the data for research, it does have to go through REB, but it is just considered part of their care data.
Excellent. Thank you so much. Great stuff. We left them wanting more. That was fantastic. Great session. Thank you all. Have a good night.